Good morning, everyone. Welcome to MedSurge, and my name is Erin Fay, and we are going to start with a GI series in your Alterations in Health 2. So in the GI series, we're going to cover appendicitis, peritonitis, cholecystitis, pancreatitis, and diverticulitis. And you'll kind of see my way of presenting. I like to cover the etiology, epidemiology, if that's present, the most common signs and symptoms, and the diagnostics that we need for this disease process. And then what is the treatment? What is the medical management? And then the most important part for us is what are our nursing interventions for each diagnosis. And you'll see that in the Canvas that I have lecture notes, and those are really detailed compared to the presentation. And I do recommend that you read it, and it will help you retain the information and organize the information. All right, so let's get started. The objectives of this course is to describe, once again, etiology, pathophysiology, what diagnostic procedures we use for each diagnosis, the signs and symptoms, nursing interventions, and medical management for patients with the following: appendicitis, peritonitis, cholecystitis, pancreatitis, and then the last one is diverticulitis and diverticulosis. So we have the pancreas has two functions, and we have exocrine and endocrine functions. And then the appendix helps us with our immune system. It helps fight against microbes and other diseases causing agents by killing them and neutralizing them. The gallbladder stores and absorbs and stores bile and helps to digest fat, and it absorbs vitamins and minerals. So where is the appendix? The appendix is in the right lower quadrant, as you can see here. Appendicitis, the definition of appendicitis is the inflammation. It's a very form of the appendix, and it results from either an obstruction, stool can get stuck in there, and we have or it can be twisted. We can have, and there's three categories. There's simple appendicitis, there's a gangrenous parasitis, or perforated appendicitis. This usually occurs with a young male population, appendicitis, and perforation is usually more common in the elderly population. If you think about that, why do you think that is? Why do you think that it's more prominent in the elderly population? My guess is that they don't seek medical help. And so they tolerate the pain, and then it ruptures. And then they present in the emergency department with a ruptured appendix and peritonitis to follow. And one of the reasons is when it ruptures, I mean, you have excruciating pain when it ruptures, but after it ruptures, it actually kind of feels a little better. The pain is more generalized. It's not so acute. And so they may not seek medical attention, and then it can lead to peritonitis. So what are our signs and symptoms of peritonitis? The most common symptom is right lower quadrant pain. It can begin with like a generalized pain and then become more acute and localized to the right abdomen. Our patients can present with, as you can see in the PowerPoint, nausea and vomiting, tachycardia, anorexia, and decreased peristalsis. And we have a good way of telling this pain location. So it's called the McBurney's point. And so the McBurney's point, if you put your finger on your right anterior iliac crest, and then your belly button, your umbilicus, And then right in between those 2 points is called the McBurney's point, and that's usually where patients will demonstrate pain. They'll demonstrate rebound tenderness. They can have spasms, and the pain is usually pretty severe, especially if you palpate it. We don't really want to palpate it. And then we can have a rebound tenderness. So we push down on there, and then they'll have a rebound, more acute pain afterwards, after we push down on there. And then once again, as I said, if the appendix does rupture, it will prevent with severe acute pain, and then the pain will decrease. So that's actually a bad sign. So if the appendix ruptures and it's not caught, they're not seeking medical attention at the time, it can lead to peritonitis. And once again, the pain is acute and then it goes away. And if the appendix ruptures and the patient is not being treated, the client is not being treated, it can lead to peritonitis. So you have this fluid in your peritoneum that doesn't belong there. So, and that's in any part of the body. So if you have a fluid in a compartment of the body and it doesn't belong there, it'll cause an inflammatory process, and which can lead to sepsis. So the signs and symptoms of peritonitis is, once again, the pain goes away. It's more of a generalized pain. Peritonitis can present with abdominal rigidity, so like a board-like abdomen. It's hard. And then once again, they can have rebound tenderness. They'll have they could lead to a septic picture, which is altered level of consciousness. They can have a really high fever, tachycardic. They can be hypovolemic. They're having fluid shifts going on, and then their white blood cell count will be greater than 20,000. And then once again, the pain will be decreased if our patients bend their right hip or knees, because that just helps with decrease the irritation in that area. So what is the treatment? We must be rapid in the treatment of appendicitis, because we want to prevent the rupture, right? We want to prevent it. So medical management for a simple appendicitis, it's just antibiotics and fluids, and they may just go home. So we would monitor, if it is a simple appendicitis, we're just going to be monitoring for pain, medicating appropriately for pain, and we would be administering antibiotics. Okay. And then if it does advance to a gangrenous, we would probably be NPO. For acute pancreatitis, our patients are NPO. And why do you think they're NPO? Well, because they have decreased peristalsis, right? And if they need to go to surgery. So our patients are NPO. So we want to monitor strict eyes and nose, provide IV fluids as ordered to prevent dehydration. We're going to avoid laxatives, enemas, or heat to that area. And the reason we avoid heat is because we don't want to put a heating pad in that area, because that could cause the appendix to rupture. It's going to vasodilate it. And then we're going to monitor for peristalsis and signs and return of peristalsis. We would ambulate if they can tolerate it. And semi-Fowler's position is one of the positions of comfort for a patient with appendicitis. All right, so the next one is cholecystitis, and this has to do with the gallbladder. It's an inflammation of the gallbladder. And it's usually caused from stones or some sort of obstruction or with the common bile duct. And then we have two kinds. We have the calculus and the acalculus. The acalculus is inflammation without gallstones, and calculus is irritation or inflammation with gallstones. So You don't really need to know that for the exam, but I think it's important that you understand the different types. We also have a uh, Cholecystitis, which is stones in the common bile duct. That's the term for stones in the common bile duct. And just so you know the terminology, so if you're looking at your patient, you can see, you can understand what that means when you're looking at the H&P of your patients. So what does the gallbladder do? The gallbladder stores bile, and bile is made by the liver. And so why is that important? So bile helps digest fats. It also helps absorb vitamins and minerals. And then after a client eats a fatty meal, the gallbladder ingests or squirts bile into the intestines to help break up that fat. And it's very important for us to be able to have this function. And we have a picture here, if you can see. So on the left side is where the gallbladder lies. And so where is that? Right upper quadrant, right? And then this is a removed gallbladder. So cholecystitis, once again, is the inflammation of the gallbladder, and it can be either calculus or acalculous, with stones or without stones. And then some people suffer from chronic cholecystitis, which is repeated episodes of obstruction causing inflammation. So what are the signs and symptoms of cholecystitis? So this is a very common disease or condition that I saw as a new nurse. I worked in Central California as a new nurse, and it was like I work on the med surg floor, and I just thought there was a special on lap choles because it seemed like everyone was getting their gallbladder removed. And once again, I came from Central California, so I have a very large Hispanic community, and most of the patients were female in their 40s and had a little tummy on them and were eating high fat foods. And so that was the population that I was experiencing as a new nurse. But there is a thing that they say about the etiology of cholecystitis. It's 4 times more common in women. And the category they used to say was fair, fertile, overweight, and 40. And so fertile means that you're still of childbearing years. So I don't know if these women were. I'm assuming they were. And risk factors for cholecystitis is obesity, diabetes, high lipids, insulin resistance. Once again, female, over 40. Pregnancy. Pregnancy can be one of the risk factors. And then they also have chronic liver disease, obstruction, biliary infection. So our at-risk ethnic groups is American Indian, Mexican American, and Caucasian. All right, so what are our signs and symptoms? We have chronic indigestion. We have right upper quadrant pain. So you saw in the picture before where the gallbladder lays. And the rebound tenderness for cholecystitis is called a Blumberg sign because when you press on it, the pain may radiate to the shoulder. So if you press in that area, right upper lower quadrant, the patient may complain of shoulder pain, and that is called the Blumberg sign. All right, so the Blumberg sign. And then our patients will experience nausea, vomiting, bloating, burping after a fatty meal. They could present with a low-grade fever. And then we also have the Murphy sign. So don't confuse it with McBurney's, which is the point for appendicitis. So the Murphy sign is a patient stops breathing during palpitation. So if we are palpating in the right upper quadrant, gently, of course, below the right costal margin, the patient may hold their breath during palpation, and that is the Murphy sign. And then our patients can also present with steatorrhea. Steatorrhea is fatty stool. And so how do you know if it's fatty stool? Well, it floats. It's disgusting, but yes, the bowel movement will float in the toilet. It has a lot of fat in it. Okay. All right. So we have we covered the at-risk ethnic groups and the risk factors. So I already covered that. And then what is the diagnostics that we do for a cholecystitis? So the gold standard is a HIDA scan. And so HIDA scan visualizes the gallbladder and determines the patency of the biliary ducts. So that's really important. They can do an ultrasound. They would probably do an ultrasound in the emergency department, and then a HIDA scan, schedule them for a HIDA scan. We also have an ERCP, which is an endoscopic retrograde cholangial pancreatography. And so what this does is this allows us to, the patient would consume BNPO, and then we would go in with a camera. So it's a long, flexible, lighted tube that's connected to a computer, and we would go in and assess that way. Also, with an ERCP, stones can be removed. So if there is an obstruction, they can actually retrieve that stone, which is really nice. After a patient has an ERCP, we have to make sure anything that we do orally that's invasive, any type of visualization, and upper GI, those kind of things. So we have to make sure post-op, our nursing intervention is to make sure that they have a gag reflex present afterwards, right? We want to make sure. Okay. So once again, the HIDA scan is the gold standard diagnostic test for a cholecystitis. And then we can use the other ones. I told you ultrasound, HIDA scan, ERCP, or an MRI. All right. And then what lab values do we do for this patient? So we would do a CMP, comprehensive metabolic panel, and an ALP, which is alkaline phosphatase, bilirubin, AST, ALP, GGT, and CBC, which would include our white blood cell count. So our AST and bilirubin may be elevated due to obstruction of the common bile duct and liver involvement. Your amylase or lipase may, if they're elevated, they may indicate pancreatic involvement. And then, of course, we have an inflammatory process going on, and so we are going to have an elevated white blood cell count. So what is the treatment for cholecystitis? So we can do a surgical removal of the gallbladder, and we could manage it medically with antibiotics, antispasmodics to keep that thing from spasming and causing pain, anticholinergics, lithotripsy, which is shock waves to break up the stones, and the patient would pass the stones. And then we can have a surgical drain put in to help with the drainage. And I've seen that also. So we would, so the abdominal, we have a surgical intervention, which is called a cholecystectomy. And usually they are done laparoscopically. So if the patient comes in with cholecystitis and the surgeon decides that the gallbladder needs to be removed, they would always opt for laparoscopic cholecystitis. It's less invasive, less complications. Patients' healing time is decreased. They get to go home. So we would always opt for a laparoscopic. But sometimes we can't have a laparoscopic because if they go in there and they see that there's more problems involved, it ends up being an open surgery. And so their hospital stay will be longer. Their recovery time will be longer, and of course, more pain and risks. All right, so laparoscopic cholecystectomy is removal of the gallbladder through an endoscope. Post laparoscopic cholecystectomy, a patient would exhibit maybe some mild shoulder pain, And this is common up for 1 week after surgery because there's some residual carbon dioxide that is used to inflate the abdomen for laparoscopic procedure. And it just causes some pain, but it will dissipate. Okay. You can watch this video and it shows the laparoscopic cholecystectomy. All right, so what are our very important nursing interventions? So once again, if a patient has surgery and they end up doing an open open cholecystectomy, they may come back with a drain. They may have found more obstructions. They may put in a temporary drain to help drain the bile and remove the drain when it's appropriate. So it's called a percutaneous transhepatic biliary catheter drain. And sometimes they don't have to go to surgery. Sometimes they can put that in under imaging, CT or ultrasound guided. All right, so what are our nursing interventions for cholecystitis? So if a patient is had surgery or has not had surgery. So if a patient is keeps their gallbladder, okay, and they're being discharged and they're overweight. So we want to encourage a low-fat diet, right? Healthy diet, heart healthy diet. So low-fat, healthy diet if the patient is obese, and then maybe some calorie restrictions. And then if they've had a cholecystectomy and so they had their gallbladder removed and they're of normal weight, they can just have a regular diet. They don't have to restrict their diet at all. So remember that. So if the patient is obese, and we would recommend a low-fat, healthy diet. If the patient is of normal weight, patients can tolerate a regular healthy diet, which is moderate in fat. We want to make sure to see if there's any liver or pancreatic involvement because that's really important. So if you have a patient post-op cholecystectomy, our nursing interventions is we're going to assess for pain. We're going to assess for return of peristalsis after surgery. Before surgery, our patients would be NPO, right? But post-op, they may be NPO. They may come back with an NG tube. And what do we do when we have abdominal surgery? So if you have abdominal surgery, you have an abdominal incision, it's going to be painful. So it's very important for us as nurses to manage our patients' pain because we need them to start moving. We need them to turn, cough, deep, breathe. We need to use incentive spirometer. We want to prevent any pneumonia from setting in. We want to put them in a semi-Fowler's position to assist with deep breathing. And once again, if they do have a drainage, make sure if they have a drainage tube, it's called the T-tube. We want to make sure it's not kinked. We don't want to obstruct that at all because that would cause more complications, right? Okay. We want to, any surgical procedure, we want to monitor our patients for bleeding. And then we want to assess their stools. Their stools should be normal brown color, which indicates the bile is entering the duodenum properly. All right, so that is cholecystitis. And then next we're going to be talking about the pancreas, which is a very important organ for our health. So pancreatitis. So pancreatitis is the inflammation of the pancreas, and it can be acute or chronic. I've seen both, and it can be serious and very life-threatening. So it's important that we understand what pancreatitis is, the pathophysiology, the cause, and of course our diagnostics and our medical management, and then our very important nursing interventions. So, all right, let's get started on pancreatitis. All right, so the pancreas. The pancreas has exocrine and endocrine functions. The exocrine function is the digestive enzymes, And the endocrine function is the alpha cells, which creates glucagon, and beta cells, which creates insulin. And I know you guys covered this last semester. So we're talking about pancreatitis. So it's an inflammation once again, and it is an autodigestion, so which means it's kind of eating itself. You have pancreatic injury. It permits the digestive enzymes to leak into the pancreatic tissues. The enzymes start breaking down the tissue, the cell membranes, and then you start having vascular damage, which leads to edema, hemorrhage, and necrosis. Then you have trypsin, which initiates pancreatic digestion and activates lactase, which dissolves the elastic fibers of the blood vessels within the pancreas, causing hemorrhage. And then you have your kinins, which cause vasodilation and increase capillary permeability. And then you have your phospholipase, which causes necrosis of the pancreas. So you can see this is very, very damaging to the pancreas, and it's important that we understand that. As more cells destroy the pancreas, more digestive enzymes are released. We have an increase in inflammation that affects the peritoneum and the pancreas. It can lead to abscesses, which can eat through the bowel and trigger sepsis. In severe acute pancreatitis, total autodigestion and pancreatic destruction can lead to DKA, shock, coma, and death. So this is very serious, and I see it a lot in the hospital. So we have two causes of pancreatitis. So we have acute, which is an obstruction of the pancreatic or common bile duct, and alcohol consumption. So alcohol consumption, and we're talking large alcohol consumptions, can cause pancreatitis. We have toxic effects of certain drugs, and then trauma to the pancreas. So if they were in a motor vehicle accident and they caused abdominal injuries, can cause pancreatitis, and then infection. And then we have chronic pancreatitis. So we have a progressive, destructive, and this is usually the chronic pancreatitis. These are the patients that you keep seeing back for the same diagnosis a few times a year. And it's usually due to heavy alcohol consumption. That is the most common cause of chronic pancreatitis. These patients, we talk to them about drinking, and of course, we can teach all we want, but they have to want to change their habits of drinking. It causes chronic obstruction of the pancreatic duct. They can have an autoimmune pancreatitis, and then sometimes it's hereditary, and then sometimes we just don't know why they keep getting it. So there's your chronic. All right, so what are the signs and symptoms of pancreatitis? So for the acute stage, we have, which is the autodigestion, we have mid-gastric or left upper quadrant pain. Our patients can present, it can come on suddenly, and they can present with jaundice, nausea and vomiting, abdominal distension, tachycardia, fever. So they can have left lung pleural effusions. And why do you think that is? Well, that's because of the anatomical location right there. And as I mentioned before, we're increasing our permeability. And so they can have fluid shifts, and they can end up with a respiratory distress. And so left lung pleural effusions is one of the common signs and symptoms of pancreatitis. And they can present with gray Turners. And so gray Turners is a gray bluish discoloration of the flank. And as you can see, I have pictures there. So this is the gray Turners right here. And then the Cullen sign, which is a gray-blue discoloration around the umbilicus. And so they're bleeding. They're bleeding into the tissue here. And then they can present with fluid shifts, dehydration, hypotension. So when you have fluid shifts from the intravascular going into the interstitial, right? And so when you have fluid leaving the intravascular into the interstitial, your cardiovascular system has to work harder. So you've got an increased cardiac output, and so your patients eventually, if this is left untreated, become hypotensive, hypovolemic, and can have electrolyte imbalances. They can lead to multi-organ system failure, shock, and DIC. Our patients will present, once again, we can have hyperglycemia and diabetes and hypocalcemia. So we will talk about hypocalcemia more, but they can have increased blood sugars and low calcium. Remember I talked about they can have change in electrolytes. They can have jaundice, dark urine, clay-colored stools, and steatorrhea again, which is the fatty stools, and tachycardia due to the fluid shifts, hypovolemia, tachypnea, increased respiratory rate. So they would have increased heart rate due to the pain, due to the infection process going on, the fluid shifts, and increased respiratory rate, tachypnea. And they can present also with shortness of breath due to the pleural effusions. So what diagnostics do we do for pancreatitis? So we would draw labs. We would do pancreatic enzymes. So amylase rises 6 to 24 hours after onset of the pancreatitis. So 6 to 24 hours, and it returns to normal in 2 to 7 days. So it is the most common lab value drawn for diagnostics for pancreatitis. However, the lipase is more specific to the pancreas and may remain elevated for up to 14 days. And I like to know this because sometimes when you have a patient on the med surg floor, they were already in the ICU. And so by the time you're getting them, it's longer period of time that they were presenting with pancreatitis. So the lipase is just a little more reliable. All right. And once again, I said they would present with hyperglycemia. So we want to make sure we check their blood sugar, their electrolytes. They have calcium deficiencies, calcium forming complexes develop fatty acids, and they've been known to set free in the retroperitoneal, which causes hypocalcemia. And then elevated white blood cell count, so we need a CBC, and then we're going to check the liver also. So we're going to do an LDH, AST may be elevated, because as I mentioned before with our chronic pancreatitis, we have a lot of large alcohol consumption patients, and so we want to see how their liver is working also. And then we can do an abdominal ultrasound, which would actually show us some stones, and we can do a contrast enhanced CT, which is more diagnostic for pancreatitis. It will just give us more detail. So what is our treatment? So first of all, our patients are going to be NPO. We don't want them eating. We would have most likely an NG tube to lower intermittent suction. And we would be giving pain medication. So we want to prevent acute exacerbation. So we are treating the signs and symptoms. So our patients are nauseated, so we can give antiemetics. We would give pain medications. We would be giving pancreatic enzyme supplements for pancreatic insufficiency. Our patients are going to be, once we advance their diet, we would advance to a low-fat diet. So initially they're NPO, okay, until the physician writes otherwise. And then once their symptoms start subsiding and their labs start normalizing, then they would transition them to a low-fat diet. And this is to reduce the discomfort and the steatorrhea. Medications would include, as I mentioned before, antiemetics, antispasmodics, antacids, anticholinergics, to decrease the vagal stimulation and the pancreatic enzyme secretion. And Then if this doesn't work, then a surgical procedure, which is a pancreatic resection. So what are our nursing interventions? So we went over the signs and symptoms. So of course, a good assessment. We want to assess do a respiratory assessment, because remember, they can get pleural effusions, they can get pneumonia with pancreatitis, and because of the fluid shifts. Strict INOs, right? We want to know what comes in and what's coming out. It's very important to prevent hypovolemia. And then assess our NG tube, and we're going to be assessing for peristalsis. If they're long term, they may not get any food, and so they may be getting TPN. And so remember, with TPN, you have to have a central line. So TPN is central line nutrition. It's got fluid, electrolytes, and glucose. So those are important. And then we want to manage their pain appropriately. So monitor for pain and provide rest periods. We want to decrease the stimulation of the pancreas. So how do we do that? So if we're giving TPN and they have an NG tube, it's important that we don't bring food into the room. Why? Because when you smell the food, it stimulates that. So it will start causing them to spasm. So it's important that we keep that away. And we want to have scheduled rest periods. It's really important for these patients. And then we want to monitor for complications, monitor for pancreatic abscess. So how do you monitor for that? And that would be increase pain, increase heart rate, increase respiratory rate, abnormal lab values, and then you would notify your provider right away. And remember, the most common and fatal complications of severe pancreatitis is hypovolemia and hyperglycemia. All right, so that completes pancreatitis. All right, so now I'm going to talk about diverticulitis, and diverticulosis. So a diverticulum is a little pouch, like a herniation of the mucosa through the muscular wall or any portion of the gut. But most commonly, it's in the sigmoid colon. And the causes are congenital weakness, or increased pressure in the lumen. So diverticulosis means that there is an inflammation process going on, and there's multiple diverticuli. So that's what diverticulosis is. And then diverticulitis is the inflammation of that diverticulum. So once again, diverticulosis means that they have the outpouching. And then diverticulitis is those little outpouchings are inflamed. Okay, so it's an inflammation of the diverticulum. So what are the signs and symptoms? So the most common cause of this is colon disease, which is usually due to poor diet. We have a high processed food diet, low in fiber, and that can be the causes of diverticulitis. And we can have complications of diverticulitis. We can have a hard mass that's sitting in there, and it doesn't pass through the colon, and it can cause an abscess, a fistula, a bowel obstruction, peritonitis, and hemorrhage. So it can cause an obstruction, and if the digested food cannot move through the digestive system, then it can cause a rupture, peritonitis, and hemorrhage. All right, so signs and symptoms of diverticulitis. So depending on where it is in the abdomen, but they can have constipation, and then diarrhea, and then lots of flatulence. It usually occurs in the left lower quadrant, and it can be relieved with having a BM. So a patient can complain of pain, and then all of a sudden they have a BM and the pain has gone away. Signs and symptoms may increase after they eat, or after activity that increase their intra-abdominal pressure. So what activities would you think that would be? That could be heavy lifting, working out, those kind of things, using the abdominal muscles. And then if you see any rectal bleeding or if there's a fever, then there is an infection process going on. So complications, once again, are abscesses, fistulas, bowel perforation, and sepsis. Diagnostics for diverticulitis is complete history and physical. We would do an abdominal x-ray, maybe an abdominal CT or ultrasound. We would check a CBC because we want to know what their white blood cell count is, and then a possible colonoscopy. All right. So what is the treatment? First of all, is we want our patients NPO. We want to rest the bowel. Okay, so we're not going to give them any food. We're not going to bring food into the room. We don't want to stimulate that GI tract. And then antibiotics for the infection. We're going to give fluids and then replace electrolytes as needed because we can draw a comprehensive metabolic panel and monitor their electrolytes. We're going to avoid laxatives or enemas. We don't want to stimulate that. We want it to rest. We don't want them to be having diarrhea. We don't want them having peristalsis. We just want it to rest and stay calm for a while and while we're giving the antibiotics. All right. And then a surgical intervention, which would be a colostomy. Okay, so it's a colon resection is a colostomy, or a temporary loop colostomy. And so that's when we remove the part that is necrotic. So if we have a part that is necrotic, they can remove that portion of the colon and create a colostomy, an outside pouch for the stool to be evacuated that way. And then when they heal, they can close the colostomy and do an anastomosis of the colon back together again. So nursing interventions for diverticulitis, once again, NPO. As we advance the diet for the patient as they're healing, we would do a soft fiber diet. And this is for diverticulosis. So if a patient comes in with diverticulitis, remember they have the inflammation. Diverticulosis just means that they have the pouches. There's no infectious process going on. So we would recommend a high fiber diet for diverticulosis. And then fluids. We want our patients to drink lots of fluids. So this is sort of your discharge teaching for your patients. So they were in for diverticulitis, they got the antibiotics, they were rested, they were NPO, and they started healing, right? And so we rested the bowel, and then they start healing. So then we're going to start doing our discharge teaching. Are they always going to have the diverticulosis? Yes, they're going to have those outpouchings. We didn't remove them, right? But how do we prevent diverticulitis from happening again? The way we prevent diverticulitis from happening again is we need these patients to have regular bowel movements. And how do we teach our patients to monitor this and to have a healthy diet? So we want a soft, high fiber diet, fluids, which means, we want them to have 8 glasses per day. All right. And then we want them to have high vegetable diet, which means raw vegetables, salads, green vegetables. It's just really important. And then we need them to monitor for their daily BMs. And we want also to teach our patients to avoid increasing their intra-abdominal pressure. And that would include heavy lifting, restrictive clothing, those types of things. I would also recommend that we teach our patients to have daily activity, right? So walking actually encourages your bowels to move, fluid, those kind of things. And so daily exercise is another really important aspect of having a daily bowel movement. And then we want them to notify their physician if they have any changes in their bowel habits, if they have fever, increased abdominal pain, all that kind of stuff. All right, so now we're going to review. We're going to kind of put all the pieces together. And I think one of the easiest way to recall this information, retain this information, is to think about the anatomical location of where the pain is, okay? So we started with appendicitis, and the appendicitis is the right lower quadrant pain. We went into cholecystitis, which is the right upper quadrant pain. And pancreatitis is the left upper to mid gastric, and then diverticulitis is left lower quadrant. Okay. And let's review the terminology. So you guys learned some new terminology. And so we have Blumberg sign. And so the Blumberg sign is pain that radiates to the shoulder, and that's for your cholecystitis. We have the Murphy sign, which is for cholecystitis also, and that's when the patient holds their breath when you're palpating. McBurney's point is the anatomical location. So from the right iliac crest to the umbilicus and the point in between, and that is for your appendicitis. Your gray Turner's and your Collins sign is bleeding. So if you think of bleeding, think of the pancreas, right? So pancreas or liver, but right now we're talking about the pancreas. So we're the Collins sign and the gray Turner sign are gray, bluish discolorization. The gray Turner's is of the flank, and the Collins sign is of the around the umbilicus. And I usually remember that because it is Collins starts with a C and it's circular. It goes around the umbilicus. That's usually how I remember that one. And then diets are real important on this material. So what kind of diet are we having for these patients with these diagnoses? So appendicitis, the patient is NPO. And then acute appendicitis, the patient is NPO. Okay. Cholecystitis, cholelithiasis is NPO to low fat. Post-op cholecystectomy, if they're of normal weight, they can have a regular diet. If they're overweight, then we would recommend a low-fat diet. Pancreatitis not during an acute phase would be low-fat. Pancreatitis in the acute phase is NPO. So, and then diverticulosis, we want our patients to have a soft diet, rich in vegetable fibers and plenty of fluid. And remember, we want them to exercise. Peritonitis, NPO, absolutely, and diverticulitis, NPO, and possibly TPN. Remember, with diverticulitis, we want that bowel to rest so it can heal. And then you should remember the most common complications of each diagnosis. So appendicitis, it can rupture and lead to peritonitis. Peritonitis can lead to sepsis. Cholecystitis, the most common complication of cholecystitis is pneumonia because they have pleural effusions. All right. And pancreatitis, hypovolemia, and hyperglycemia are the most common complications of pancreatitis. And the most common complications of diverticulitis could be abscess, obstruction, bowel obstruction, or fistulas. So those would be emergent situations. A bowel obstruction would need emergent surgery. All right. Well, that concludes our GI series, part 1. I look forward to seeing everybody in class. We're going to review case studies. We'll have a quiz. We'll do a Kahoot. And please, if you have any questions, feel free to ask. You can email me, and we can discuss them in class. I look forward to seeing everyone. Thank you.